Well, thank you. It's been a pleasure to be a part of this excellent symposium, and I look forward to coming back in future years. I think it's been a very educational effort on everyone's part. So the subject I'm going to deal with today, some of it will be a little bit repetitious. I'm going to cover some of the things we talked previously about the interventional management of aortic aneurysm, some historical perspective, and where we are now, where we're going in the future. I have no disclosures relevant to this talk. The treatment of abdominal aortic aneurysm is to prevent rupture. That's the primary outcome. It's not to improve all-cause mortality or to cure stroke or heart disease or renal disease or obstructive lung disease in patients. So I think it's very important that one understand that what we're doing when we're treating an aneurysm is we're preventing it from rupture. And that's the goal of all forms of treatment. Time-tested treatment for this process has been direct surgical repair. We've been doing it for about 50 years or more. The disadvantages are that it carries a significant mortality, somewhere between 2 and 8.5%, depending upon which database you use. And the morbidity range is anywhere from 10 to 15%. And most of these morbidities are significant. They're pulmonary, cardiac, and renal. The endovascular treatment of aortic aneurysm was developed to provide a comparable therapy for direct surgical repair and to protect the patient from rupturing his aneurysm. It minimizes the need for intensive monitoring and intensive care time, should shorten the length of stay, and it certainly does that, and has a lower perioperative mortality and morbidity, 1 to 3% mortality, and again, about a 3 to 5% morbidity, most of which are related to groin wound complications and some minor other events. So when do you use each treatment? That's a question certainly open to considerable controversy, but in general, I think the philosophy has been that young people, younger patients with a long life expectancy and few comorbidities and have anatomy unsuitable for EVAR are certainly considered patients for open surgical repair. I think that's even true today, although it's becoming less and less true because I have many young patients who come to see me who are in their late 50s or early 60s who really do not want an open surgical repair. EVAR, on the other hand, has been somewhat recommended for older patients with a reasonable survival potential, those who have multiple comorbidities, people who wish to preserve erectile function, and people who have suitable anatomy for EVAR. Means that you can stay within the IFU or instructions for use for the device you plan to use. The endovascular treatment was conceptualized in 1985 by Professor Volos in Ukraine. It became a clinical reality in 1989 when endovascular abdominal aortic aneurysm repair was done both by Dr. Volodos in Ukraine and by Juan Perotti in Argentina. The first devices in the United States were approved by the FDA in December of 1999. This is Dr. Volos standing next to me in February of this year. He came to Phoenix and we got an opportunity to visit a little bit. His first case was a thoracic aneurysm that he treated with an endograft, and he delivered it through a thing that looked like a pipe that he connected to the femoral artery. It was mounted on the table. It was a very interesting device. And this is Juan Perotti, a good friend of mine who was actually for many years in the Western world attributed as the first person to do endovascular aneurysm repair. The historical timeline for a successful EVAR device in the United States: in the 1990s, there were multiple trials. Many of the devices in those trials fell by the wayside. In 1999, the FDA approved Medtronic's Anurex and Guidance Ancure. 2002, Ancure was removed from the market, not because of the device itself, but because of the delivery system, which, as has been alluded to in the TAVI programs, was large. It was 25 French, and there were multiple injuries to iliac arteries, which not always got FDA reported. In 2003, Gore and Cook devices were approved. In late 2004, Endologix was approved. The first generation Endologix device was really very user-unfriendly, but the concept was appealing and it has stuck. In 2010, the Medtronic Endurant and Endologix AFX were approved, and in 2011, Aptus Endostaple, and lastly in 2012, late 2012 trivascular ovation device was made. The endovascular treatment of the aneurysm today in the United States is limited to about 6 manufacturers. The technology is applicable to somewhere between 75 and 88% of patients, and the technical success of the endograft procedure ought to be pretty close to 99 to 100%. These are the devices starting from the left. That's Medtronic's Endurant, Cook's new device, Gore's repositional device, trivascular ovation with its large suprarenal crown, Guidant, which was a totally unsupported device except that the anchoring points is no longer on the market, and Endologic's AFX. So which is the current best endograft for treating abdominal aortic aneurysms? This is what people always ask me. And what I'm going to do is show you these slides. They're busy, I know, but I'd encourage you to just look at them a little bit. On the left-hand side, if you go down that slide, what you'll see is there's some numbers there. And what these are this is the Endologic's core lab data for the 449 patients which they submitted to the FDA for IDE approval and then followed them out. This data covers more than 5 years of follow-up for all of these patients. The next group of patients under that are 128 Endologic's patients that we treated at my institution's 2 hospitals, Medtronic Anurex and Talent, and then the number of Medtronic grafts we treated that we had 5 years of data and on down. And what you can see, I think the important take-home message of this whole slide, look at it, is freedom from rupture of the aneurysm is really quite excellent. There are very few aneurysms that ruptured over the 5-year period of follow-up. There was certainly the only device that had any really significant migration was the Medtronic Anurex, and we all know the reasons for that. It really depended only on radial force to hold it in the neck. It wasn't very easy to see where that would work well over the long haul. And then if you look at freedom from sac enlargement and freedom from graft limb occlusion, all perform pretty well. But in fact, if you look at these devices, there's very little difference between any of them. And there's one column that I didn't print on here, but the column that shows how many devices have been implanted worldwide. It's almost 750,000 since they were put out. So that's a vast number of people that have been treated with these devices. The other little summary of information has to do with the numbers of types of endoleaks that occur and what their frequency is. You can see the type 2 endoleak is by far and away the most common, and it averages somewhere in the neighborhood of between 9 and 12%. So the unmet clinical problems have been migration, endoleak, durability, difficult anatomies, need for secondary interventions, and lifelong surveillance. And of course, the naysayers who don't like EVAR say that these are costly procedures. The endografts themselves run in the United States anywhere from $10,000 to as high as $16,500 for the most recent modular device with its contralateral limb. And when you realize in our country the reimbursement for this is about $25,000, if you spend $16,500 on the device, that doesn't give the hospital much money to much of a profit margin when you start accounting for the catheter and the IVs and the operating room time and the time in the day surgery and recovery room. So the factors that influence migration: aortic neck elongates, dilates, and angulates. You have distraction forces which act on the endograft, craniocaudal forces and lateral forces. And Chris Zarins and his group at Stanford looked pretty much at the lateral forces and thought that they were about 10 times what the craniocaudal forces were. And then sac remodeling, and obviously the presence of continued endoleaks. The lateral migration, you can see here on this slide, you can see that within the aneurysm sac, a lot of the devices will move toward the wall, one wall or the other of the aneurysm. And if they do, something has to give, and it's usually the proximal attachment site, although sometimes it's an iliac limb pullout or actually a modular component separation. And this is true for all the devices. I showed you this slide the other day. Professor Greenhall looked at EVAR 1 and 2 and showed that if you had an endoleak of any type, type 1, 2, or 3, and you had sac enlargement, you were at definite risk for aneurysm rupture. And the need for interventions, again, it's in multiple series, somewhere about 19%. The cost is about 10 times to surveil people who have endoleaks and 5 times what it would be if you have to intervene on them for any reason. So the device manufacturer's challenge has been to eliminate endoleaks, to improve device conformability to match the patient's arterial anatomy, develop innovative means for endograft stabilization, many have tried to do that, and techniques for preserving important branch vessel flow. And the device, as I mentioned yesterday, there have been millions of dollars spent by a variety of manufacturers to make Me Too devices. As you noted from the studies that I showed you earlier, of the 5 or 6 devices that are out there now, they all do the job and they do it reasonably well. So to develop 5 or 6 more of the same kind of device, which tend to ignore the real problems associated with this whole treatment program, seemed to me a little wasteful, but that's how it's gone. I'm going to talk a little bit about off-label techniques for graft stabilization and side branch perfusion. And for those of you who have had problems with graft stabilization, primarily at the proximal neck, but sometimes in the iliac limbs, a large Palmaz stent, P4010 or P3010, you can use to bolster or stabilize the endovic graft's point of attachment in the infrarenal neck. You have to understand, though, that if you're going to use this device, you can't use it on devices which cannot be dilated, like the Cook device, which has a stainless steel cage for a point of attachment. You can't dilate that any bigger than it is. That's how big it is, and you put all the Palmaz stents in the world you want in there, you cannot balloon dilate any bigger than the size of that device. So it works well for endologics grafts, it works well for some of the other nitinol devices, but anything that has a fixed diameter cage, you can't help. The chimney, snorkel, and sandwiches will all be used to extend the range, and this is just an example of the chimney graft. They can be either perpendicular or spiral. And the sandwich, as you know, as Dr. Armando Lobato has well publicized, is a device used for, again, extending the stabilization of the endograft at the level of the renals and treating para and juxtarenal aneurysms. Branch endograft technology has limited availability. There's a high level of operator skill required for this, and certainly with the Cook device, there's a certain amount of manufacturer's lead time to fabricate the device to get it for use. Endologics, as I mentioned yesterday, has Ventana, which is off the shelf, but it's in an ID investigation. I think single side branch devices may be useful in the future, but I really think the amount of radiation the operator gets from doing the multiple side branch and fenestrations is pretty severe, and as time goes on, I think that will even come to the attention of most of the interventionalists, and they'll decide that it may not be worth the effort. The endologic Ventana system is a stent graft, as we talked about yesterday, that has preloaded renal access so that you take your seal zone between the superior mesenteric artery and the renal vessels. And it's a very good device for that purpose. They have had some issues with the renal arteries and their stent graft they placed in them, and their ID in the United States has been suspended for a short period of time. Cook custom fenestrated device for super and pararenal aneurysms takes some lead time. You have to have some kind of fabrication made for this so that it matches up the CT scan findings, and it requires a reasonable amount of skill to place this as well. Going toward the future, if you look at some novel solutions for most EVAR limitations, we talked about yesterday the endovascular sealing system, or Endologics Nelix, and the multi-layer flow modulator. And I'll talk just a bit about the Nelix system again. For those of you who were here yesterday, it uses a cobalt chromium covered PTFE covered stent, one from each groin, surrounded by a plastic polyurethane endobag. They fill it with a Palmer that sets, cures, and stabilizes and anchors the device. And then you have a control console for delivery. And this is just a cartoon that shows how it works. Those of you who didn't see it, it is really a very unique system. It uses the existing anatomy. And basically, if you're a believer in this system, you'll see that there really is no neck length limitation, no iliac aneurysm diameter limitation. And if you get the right endobag and the right size device, it's pretty simple to do and pretty durable. The Nelix device that went to the CE mark in Europe had one type 1A, one type 1B, early device design deficiencies, and the continuing on study of 35 more patients going, which was led in for the FDA approval. Had, as you see here, the very good results. They had only 2 small, less than 1 millimeter type 2 endoleaks, both of which thrombosed in the early follow-up period. And this showed the 2 type 1A and 1B endoleaks, again, design deficiency problems in the first generation device. And this shows you how this device can be used. If you look across the bottom, it's 1 month, 6 months, 12 months, 24 months, and actually goes out to 30 months now, 36 months. There's been no movement of those limbs at all within the sac because it's totally stable. So the sac sealing device really should ensure long-term protection from aneurysm rupture. It'll probably reduce the need of CT scans for follow-up. Follow-up will be reduced to ultrasound. And one of the things that one of the original investigator, Dennis Cravens from Latvia, told me the other day, he's used this in 2 ruptured aneurysms. And it actually works very well. And when I first saw this device, I thought it was the ideal device for endovascularly managing a ruptured aneurysm because it seals all the side branches, eliminates the problem of abdominal compartment syndrome from persistent lumbar bleeding after you do the endovascular repair. I want to mention just a little bit about the multi-layer flow modulator, and I'll go through this in just a very brief way. Some of these slides you've seen. Basically what it does, it converts turbulent flow in the aneurysm to laminar flow, and laminar flow lays down thrombus, and it preserves flow into the branches. There's some very good mathematical reasons why this works, and why the really devastating effect on aneurysm wall is the disruption of collagen and elastin, and that's done by the turbulent flow in the aneurysm sac, not laminar flow. And if you look at the finite analysis of how flow occurs and where the stress occurs on the aneurysm wall, you can see that just putting that device inside the aneurysm eliminates significantly the stress on certain areas which are predisposing to rupture. And I won't go through much of these. These are just slides that show the Moroccan experience. The technical results of that series, though, was quite interesting in that they've had no spinal cord compromise, they've lost no branches, and they had complete aneurysm sac exclusion. And these are some of the follow-up CT scans done at more than a year, some out as far as 2 years. And again, abdominal aortic aneurysm. So the multi-layer flow modulator has its CE mark in Europe. It's suitable for all types of aneurysms. Its preliminary clinical results are satisfactory. Major side branches have all remained patent, and sac thrombosis is not immediate, so you can't use this for a ruptured aneurysm. And certainly more study is required for this. As you might imagine, all of the other device manufacturers who've sunk lots of money into the fenestrated and branched endographs are not happy about seeing this device come on the market. And they will do everything they can to stand in the way of it getting on the market, because it is going, obviously it would be a lot simpler to put this in than spend 9 hours or 6 hours in the fluoro room trying to put in the branches of your thoracoabdominal fenestrated or branched endographs. This is the timeline, single side branch grafts 2012, the fenestrated off-the-shelf grafts, as you know, already started 2012, 2013. Endologic sac anchoring, that's the Nelix device, 3rd quarter of this year. And the multi-layer flow modulator hopefully is going to start some kind of a trial in the United States in some form or fashion in the 3rd or 4th quarter of this year. It has its CE mark in Europe. Thank you. Sorry I ran over, but